So I actually learned this from my patients. And that is, well, actually, let me back up just a little bit. The first thing I learned that was like really unique to NET patients, and I think you touched on this last week with Josh Mailman during your talk with him, was about trust.
Mm-hmm.
So for whatever reason, I am still looking into this. I think trust is a huge component specifically for NET patients. And that's I think due to how they kind of most patients, how they got to the diagnosis, right? So they've spent typically years and years with symptoms and feeling like nobody's listened to them, and healthcare providers, kind of the patient feeling like they've been blown off, right? Like, oh,
Yes.
that's menopause, that's IBS, that's
right. Happens all the time.
all the time. So what happens is this kind of over a period of time, it erodes this relationship with healthcare.
Good word.
And I think the most important thing when I meet someone is just to start immediately with building trust again. And it takes a while. I think it takes consistency. I think it takes respect. I think it takes openness on both sides. It's like developing a brand new relationship. So I often want to like give a lot of information, but really I think spending time listening to stories. I think people want their stories told. That's just our nature. I have an anthropology background, so I love the stories. I love our culture. I love how people integrate with each other. I think, we just want to be heard, and that just goes so far. Once you develop that, I think you can really start to have a relationship. It's actually one of my favorite things about NET patients is I see them for quite a long period of time for the cancer world, right? Like I get this opportunity to really know them, know their loved ones, know hear stories about their children. And I just think that's so meaningful to develop that trust. And then the advice that you can give is really, really individual for individuals where they're at, right? So some want a lot of information and want to get on the internet and look up everything. Others kind of put their head in the sand for a while, I think it's just listening to people and kind of giving them the information at where they're at. Patients with lower extremity edema can have tumors that are kind of impinging on our vasculature that's returning it back.
That's what she's saying,
Yeah, so sometimes I know that we, and unfortunately, we sometimes start with diuretics, which really isn't the cause of it. So not as good of a response to that. But usually it's shrinking the tumor, or sometimes we put a stent in to keep that vessel open to do that. So it's tough when it's kind of an obstructive thing that's not allowing blood and lymph flow back to where it needs to go.
Got it.
Yeah, it's tough. It's tough. Really talk to your healthcare team about that. I like to tell patients to kind of a little tip from kind of both sides, hearing it from patients and being on a provider side. It's really helpful if you get real specific about the patterns and different things. So I would say, this happens every day. Maybe it's better in the morning, but it's not much better. It's impacting my ability to walk, allowing them and being more descriptive. Tell your story about your edema and how that's impacting your daily activity, right? So maybe that's not allowing you to get the exercise that you need.
Right.
And then that can be, you can also make appointments specifically. I think this sometimes where it's more helpful to maybe have a designated appointment. This can even be with your primary care provider too, right? To really address specific things, especially if they're impacting your quality of life. Okay, again, I I wish I had more imaging up, but
Yeah.
so it kind of depends on where it is, or if you're having other kind of cardiac symptoms, palpitations, that sort of thing. Again, a care plan, should that be something that's being evaluated by an EKG, an echocardiogram? Should you see a cardiac specialist? It just really depends on the location of it and if it is currently causing symptoms.
Hmm.
Yeah, how
Got it.
large it is. Just kind of like we were talking about, the edema and blood flow. It really just depends on where things are at, and how large they are and what they're impacting. Chromogranin A, I'm
Yes,
assuming,
correct.
yeah,
Yes, yes,
blood
yes.
test.
Yes.
So chromogranin A is a non-specific tumor marker, meaning we have these certain tests that we can do that show tumor, well, we call them tumor markers, and they're different for different types. So in colon cancer, there's one. In breast cancer, ovarian cancer, we can check kind of the tumor markers. Now, not everyone's tumor marker is elevated, and chromogranin is while common, I have to be careful, while common with NET patients to be elevated,
Hmm.
it's not always, and it can also be elevated for other things, other medications. Often the class of drugs called proton pump inhibitors, or PPIs, the
Mm.
Prilosec, the things that actually a lot of GI patients use, can elevate chromogranin. And so it's or a trend for you and your cancer.
Hmm.
We can follow it, and we can track it, but it never guides our treatment solely. So take that for what that is. It can be helpful.
Hmm.
It can be helpful in some cases to maybe potentially get a scan sooner if it's like rising and rising, and it's, maybe that's something that we would do, but never by itself do we make treatment decisions about it. Okay, so twofold. Your celiac is probably some portion of that, and often, Charlie, this brings up a really great point, is that typically the things that we're trying to manage or control are usually multifaceted, right?
Hmm.
So it's not just one thing that we need to do to improve that. That's true of diarrhea, abdominal pain, that kind of thing. So the first is to address celiac issues, and the other to talk to your provider about is, what are the things that I need to look out for after this surgery. So, for example, in my survivorship clinic, I'll talk about, any abdominal surgery can kind of risk with what we call adhesions, kind of start fibrosing and kind of twisting and kinking. This can happen over time, your intestines, and you can get abdominal pain. You are higher risk for small bowel obstructions, these kinds of things. And so what you want to do is ask, what are some potential risks of the things that I had? Not that they're going to happen, but it helps prepare you so that if you do get severe pain or can't somehow manage that, you know what steps to do for that. So, for example, I'll give a care plan for patients who've had some sort of small bowel resection, and on it will be one of our late effects could be a small bowel obstruction, and I will write out why that's so. And then my patients will take a picture with their iPhone of their care plan. So if they end up in the emergency room, they can show them, like, I'm at higher risk for this. This is something I'm concerned about, could potentially be happening because I've had, a net and this removal of that. So I think ask specifically about, from
Hmm.
your surgeon or your medical oncologist, whoever you're having your visit with, about what does this mean now, and what am I at higher risk for, and how do we kind of work it up. If it's more acute, obviously needs like sooner attention, but So I hope that kind of helps.